is a thrombolytic checklist. So there's those patients there's an inclusion criteria according to UpToDate, and then there's an exclusion criteria. So the inclusion criteria is a clinical diagnosis of ischemic stroke causing measurable neurologic deficits. The onset of symptoms less than 4.5 hours, and the patient should at least be 18 years or older. And then there's a whole lot of contraindications. I do think that it's impossible for anyone to remember all of these. So it's just important, again, I think that in any casualty and in any ED, a thrombolytic checklist should be available so that we can quickly go through it when we see these patients. All right, so going into the acute management, again, this management was taken from the standard treatment guidelines hospital level. So the first thing that you'll notice here is that the cutoff has been taken as 3 hours, while theoretically the cutoff is actually 4.5 hours. So if the patient's symptoms have been there for 3 hours or less, you do not give aspirin to these patients. You refer immediately to a hospital that can administer thrombolysis. If thrombolysis is being given, alteplase is given IV 0.9 milligram per kg to a total dose not exceeding 90 milligrams. 10% of the total dose is given as a bolus, and the remainder continued as an infusion over an hour. And then for those patients who have had their symptoms for more than 3 hours, or it is not known when the symptoms started, we give aspirin 300 milligrams stat, followed by aspirin 150 milligram daily. If unable to swallow, we can administer this via NGT. Do not administer aspirin if there are symptoms suggestive of a subarachnoid bleed, such as a headache, neck stiffness, nausea and vomiting, and so forth. And then for DVT prophylaxis, they recommend rivaroxaban 10 milligrams per oz daily while hospitalized. And then if rivaroxaban is contraindicated, then enoxaparin 40 milligrams subcut daily, or unfractionated heparin 5,000 units BD. Going into the fluid management, so intravascular volume depletion is frequent in the setting of acute stroke, especially in the elderly, and it may worsen cerebral hypoperfusion. So isotonic fluids are preferred, an example of which is normal saline. Hypotonic fluids are best avoided as they can worsen cerebral edema in these patients. And then glucose-containing fluids are also best avoided as they can worsen hyperglycemia. Fluids should, however, be individualized based on the patient's cardiovascular status, electrolytes, and other factors affecting fluid status. And then hypo and hyperglycemia. So hypoglycemia can cause focal neurologic deficits mimicking stroke, and severe hypoglycemia alone can cause neuronal injury. So it is important that hypoglycemia be corrected promptly. A sliding scale can be used. Sorry, I mean thingy. You give your patient 10% or 20% dextrose. And then in the case of hyperglycemia, hyperglycemia is common in the acute stroke patient and is associated with poor functional outcome. Hyperglycemia may worsen brain injury by several mechanisms. Hyperglycemia may also rarely present as a stroke mimic. So the American Heart Association, American Stroke Association guidelines for acute ischemic stroke recommend treatment for hyperglycemia to achieve a serum glucose .
Hi, Madeleine, we have been cut off from our side.
Unmute.
Apologies, I don't even know how we got muted because we're not in Teams at all. Can you hear us now?
Hello?
Yes,
We can hear you.
Can
Yes,
you
we
tell
can
us
hear you.
when you were able to see the slides?
Yes, we can.
Can you tell us when we lost? Shall we go back to the previous slide?
Yes, please. There we go. Thank you.
Right. I'm not sure how that happened because we haven't touched the screen at all. Shall we start at this slide again or shall we go to the next slide?
I think just recap on this slide and then continue to the next one, please.
Everybody here? Okay.
All right, so swallowing assessment. Swallowing difficulty is common after stroke and poses the risk of aspiration pneumonia. It is important to assess swallowing function before oral medication and food can be given. Prevention of aspiration in patients with acute stroke includes initial nil per hour status until swallowing function is evaluated. So I got this example of the swallowing assessment from the Center of Stroke and Cerebrovascular Disease. So you basically check, is the patient's GCS less than 13? Is there facial asymmetry or weakness? Is there tongue asymmetry? Is there palatal asymmetry? And then if the answer to all of these is no, then you move on to the 3-Oz water test. So what the 3-Oz water test is basically you giving 90 ml of water to your patient to drink continuously. And then if there's any signs of choking, a cough, throat clearing, then you quickly stop. This is best done with your patient at 90 degrees. So if this happens, if the patient coughs or clears their throat in some way, then they need to be kept nil per Oz and await a formal assessment by the speech therapist. I do understand that there's many other ways of doing this. I think in our standard treatment guidelines, they recommend giving 10 ml of water to your patient. And then head position, the head should be kept in neutral alignment with the body and should be raised at 30 degrees for patients in the acute phase of stroke who are at risk for any of the following problems. So elevated intracranial pressure, such as in those patients with intracerebral hemorrhage, cerebral edema for longer than 24 hours from stroke onset in patients with large ischemic infarction. And then in those patients with risk of aspiration, such as those with the dysphagia or diminished consciousness. And then for those patients with cardiopulmonary decompensation or oxygen desaturation secondary to a chronic cardiac or pulmonary disease. In the absence of the above, it is recommended that the patient be in a position that is most comfortable to them. And then in the case of a fever, the source of fever should be investigated and treated, and antipyretics should be used to lower temperature in febrile patients with acute stroke. Common causes of a fever in these patients include aspiration pneumonia and urinary tract infections. And then blood pressure management. So the approach to blood pressure management in patients with acute ischemic stroke is different from the blood pressure management in patients with acute hemorrhagic stroke. Neuroimaging is important not only for the decision on whether to thrombolyze or not, but also to guide blood pressure management. The arterial blood pressure is usually elevated in patients with an acute stroke. This may be due to chronic hypertension, an acute sympathetic response, or other stroke-mediated mechanisms. In many cases, the acutely high blood pressure is important to maintain brain perfusion in borderline ischemic areas. In patients with acute ischemic stroke who are eligible for intravenous thrombolytic therapy, before thrombolytic therapy is started, treatment is recommended so that systolic blood pressure is less than or equal to 185 millimeters of mercury and diastolic blood pressure less than or equal to 110 millimeters of mercury. The blood pressure should be stabilized and maintained at or below 180 over 105 millimeters of mercury for at least 24 hours after thrombolytic treatment has been given. For patients with ischemic stroke who are not treated with thrombolytic therapy, blood pressure should not be treated acutely unless the hypertension is extreme, like in the case of a systolic blood pressure more than 220 or diastolic more than 120. Or in those patients with active ischemic coronary disease, heart failure, aortic dissection, hypertensive encephalopathy, preeclampsia or eclampsia. If acute antihypertensive therapy is needed, intravenous agents are generally used. However, in our standard treatment guidelines, it states that if the blood pressure is more than 220 over 120, you give amlodipine 5 milligrams or HCTZ if the patient's fluid intake can be ensured. There is evidence of harm when blood pressure reduction is done within 7 days of a cerebrovascular accident. For this reason, cautious reintroduction of treatment should be done after 7 days. And then for secondary prevention, all patients with a thrombotic stroke not on anticoagulation and irrespective of LDL should receive aspirin 150 milligrams per ounce daily and simvastatin 40 milligrams nocturne. Patients on protease inhibitors receive atorvastatin 10 milligrams, and then patients on amlodipine and not on a protease inhibitor receive simvastatin 10. If the patient complains of muscle pain, you reduce the dose to simvastatin 10 or consult a specialist. And then for those patients requiring anticoagulation, in patients with cardioembolic stroke, such as those patients with atrial fibrillation with no hemorrhage on CT scan, the optimal time to start anticoagulation varies between patients, starting from 7 to 14 days, but it can actually go up to 21 days. Bridging the anticoagulation with heparin or earlier initiation of warfarin is not recommended. So when do you refer those patients? So patients with aspirin intolerance, and then to a facility with a CT scan, patients with atypical presentation, patients with ischemic stroke who may benefit from thrombolysis, patients with suspected posterior cerebral fossa hemorrhage who may benefit from decompression, and then also if there is a history suggestive of subarachnoid hemorrhage or there is neck stiffness. And then moving on to the transient ischemic attack. So a TIA is defined clinically by the temporary nature of the associated neurological symptoms, which last